So welcome to this joint ODI, CARE, GSK and London School of Hygiene session on public-private partnerships in healthcare, particularly in Asia, and we will share some particular case studies of work that CARE and GSK have been doing together. Welcome as well to our online audience. I hope you can hear us well. Maybe even see us, actually, looking at the camera up there, yes. For people both online and in the room who've got their phones with them, please join the conversation on Twitter. We have a hashtag MNCHAsia, and we have Twitter handles of ODI Dev at CARE-Int UK, which I think you can see up there. There's also at GSK, of course, and you're welcome to share yours, Cara, if you want. I don't have that one in my head, I'm afraid. Just a couple of housekeeping things first. As you probably saw, the bathrooms are just to the right of the main entrance as you walked in, just to the right of the lifts over there if you need them. There is no fire drill planned today, so if we hear a fire alarm, it's real. We can probably just leave back through the front door that you came in and get away from the building, across the road. If we can't go out that way, there's a fire escape that way down the corridor. There is normally Wi-Fi available if you've been to events here before, but ODI had a kind of a hack yesterday, so the Wi-Fi is not working, and if your phone's connected to their Wi-Fi automatically, you might want to disconnect from that and just use your mobile roaming. But please do that so you can join in on Twitter. Okay, so thank all of you for coming and listening. Thank you to all of our speakers for coming, and thanks to the ODI for hosting this. As I say, yes, so we're going to be talking about public-private partnerships in health, and particularly the role, therefore, that the private sector can play in international development. CARE, which I joined just over a year ago, works a lot with the private sector. And we do so because of the impact we think that can have. The private sector has a lot of reach in terms of its customers as well as its employees. And that means that we can reach a lot of people, so we can get scale. We also think there's some inherent sustainability in working with the private sector. If people can benefit in a way which is also a profitable business for somebody, then that work can continue long after a development project might be able to be sustained. And we saw a bit of that in Bangladesh last week, and I'm sure you'll hear a bit about that from some of the panelists. And also fundamentally, one of the key dimensions of poverty, of course, is economic poverty, and the private sector clearly has a huge role in terms of giving people economic opportunities and putting resources in their pocket to invest in the kind of things that they want. So we work a lot with the private sector, and we feel that we've got a lot of experience, both of what works and perhaps what doesn't. We want to share a bit of that with you today. And particularly, we've been working with GSK on this programme that Darryl and Jahangir and Fiona will all tell you more about. This amazing investment by GSK of 20% of its profits in all the least developed countries where it works back into the health systems of those countries. So really amazing programme. And I've been lucky enough to see that programme in operation in a couple of countries, both in Afghanistan, where it's an urban-focused programme, because some of the more disadvantaged urban populations aren't covered by the kind of major government rural community health programme there. And so it's very good to see that. And it's having a real impact, and we're seeing dramatic falls in terms of infant mortality and maternal health problems there. Infant mortality had fallen from 15 to 10 per 1,000 live births in the duration of the project for the last 3 years. And last week, a few of us, Darryl and I, were in Bangladesh with Dr. Jahangir, and seeing our work both in urban but particularly in rural areas, very remote rural areas of Bangladesh, meeting some of the health workers and midwives who've been trained under the project, and it was really interesting to see the kind of economic empowerment that was for them as individuals to be coming out of the house into sort of trained, well-paid, respected jobs. But again, also the impact it was having on the health of mothers and children in the community, and in particular really startling to see that births had gone from being only one in 8 attended by a skilled birth attendant to 1 in 2, and very interesting that it was both the government services and the services provided under the project that were being used more as a result of the kind of community mobilisation, explaining to people why skilled birth attendants were so important. So I'm really pleased to have seen the work in action, and you're going to hear a bit more about it in detail from our speakers. So let me tell you who our speakers are, and then I'll give us a slightly longer introduction to each of them just before they speak, so you don't have to remember all of the background in one big go. But our speakers are Darryl Burnaby from GSK, who is the Global Community Partnerships Manager, which includes, but is not only about managing the 20% reinvestment programme. We have Fiona Samuels from here at the ODI, who has been working with us on these brochures, which you will have or be able to take away at the end, researching into the impact of the programme. So we look forward to hearing from you about those. Thank you. We have Dr. Jahangir Hussain, who is our Director for Health in Bangladesh for CARE, and so oversees the community health work that we do with GSK, as well as several other health programmes in Bangladesh. He'll tell you a bit about that. And Cara Hansen from the London School of Hygiene and Tropical Medicine, where she's the Professor of Health System Economics, and will sort of draw out some of the broader lessons, perhaps, for the role of public-private partnerships in the health sector. So that's the plan for today. So we will go to our... and then obviously there's going to be time for Q&A and discussion from all of you. We're planning to leave plenty of time for that. So we should have about 15 minutes for each of the speakers, which will leave us almost an hour for discussion with you and your questions and comments and discussion. So that's the plan. Okay, so first of all, we're going to hear from Darryl. Actually, I'll give you the clicker so you can get ready. So it's just forward and back. Ignore the other 2 buttons. Okay. Darryl joined GSK in 1999, has held a number of roles before joining the global health programmes within GSK's Africa and Developing Countries unit 4 years ago. That team's focused on improving access to healthcare in the world's poorest countries. And as I've said, Darryl manages GSK's programme, which reinvests 20% of its profits in the world's least developed countries. He has a passion for developing innovative private-public NGO partnerships to improve access to health, and champions GSK's approach to responsible and sustainable business. He has a degree in natural sciences from the University of Cambridge and a PhD in chemistry from the University of Southampton. And he's going to tell us a bit more about the overall 20% reinvestment programme, and particularly his impressions of how it works in Asia, which is where CARE is implementing it. So, Darryl, over to you.
Okay, thanks very much, Laurie, and thanks everybody. Delighted to be here this morning and have an opportunity to talk a little bit about the work that we do in our global health programs team and in the 20% reinvestment initiative. And before I get into too much of the detail about the program, I just want to expand a little bit on the fact that when I joined the pharmaceutical industry back in '99 as a graduate, my wish, I guess at that time, was to having a background in science, be part of an organisation that could use that science to support, to support access to healthcare. And I didn't know very much more than that at that time. And the pharmaceutical industry was not in that position particularly then, but very fortunately in the last 10 or 15 years, and particularly in the last 7 or 8, we've really started to think hard about how we evolve as an organisation, and rather than be one that does business and then thinks a bit about what we need to do corporate responsibility, actually recognise our role, our critical role in society, and to try and to develop a responsible approach and build a business around that. And I'm part of I guess of that generation where we've been thinking hard about how to do that and turning that into action. And part of the thinking there has really been we need to be an organisation that does more than invent, develop and sell medicines. We've done some great things in reducing prices and improving the affordability of medicines. But we need to go even further beyond that and think about how do we get those medicines from our factories into the hands of the patient in the last mile. And this programme is very much about how we set up a platform to do that. So this is a non-commercial programme in that it doesn't directly promote our products, but it is absolutely about creating an environment where people can have access to healthcare. So it's primarily focused on a societal benefit, but ultimately also it's helping to create a platform for GSK in the future. And we hope that that's the new responsible approach to business that will continue and that will actually act as a beacon to other organisations going forward. So I'll spend a little bit of time now just going through some of the details of the programme that we're talking about today. So one of the challenges in healthcare in the 21st century, and before that really, is that there is a huge shortage in developing countries of access to skilled health workers. And if you don't have a health worker, then somebody in the last mile communities do not have access to the health system. So health workers at the frontline level play a critical role in linking those most underserved communities with public health systems, and they're very fragile. And the quote that you can see there, I'm not going to go through all the details of the slide, but what it fundamentally articulates is that there is a huge shortage of workers, of health workers at the community level. And that number, 7.2 million, is almost certainly now out of date. It's probably 8 million, 9 million, because that's from over a year and a half ago. But the issue here is really that there is a huge shortage of skilled health workers at the community level. And training those health workers is a low-cost, high-impact means of improving access and linkage between communities and public health systems. And so 5 or 6 years ago, GSK made a commitment to reinvest 20% of its profits in the world's 50 poorest countries into improving access to healthcare. At the time we made that announcement, we weren't totally clear about where we would put those profits. We could have put them into building hospitals, we could have put them into improving supply chains, and they're very worthy things and important issues to tackle. But following a consultation, actually, that Dr. Jahangir was part of 5 or 6 years ago, the important theme of the lack of trained health workers was really apparent. And GSK made a commitment to focus that 20% reinvestment programme into training health workers at the community level. And the range of health workers is quite broad, so it goes from volunteers to community health workers to health extension workers, midwives, nurses, pharmacists, but all of them do really play that role in linking communities to public health systems. And that's what the challenge really was. And so, as I've just said, the solution that GSK had was to focus that programme in that way, and that enabled us to have a very consistent approach across the least developed countries. So wherever we made a profit in any of the world's 50 poorest countries, 20% of that profit went back in. And I get asked sometimes, why 20%? How did you come up with 20? Why was it not 5? Why was it not 50? Well, I think the whole question there really, or the whole answer to that, is really about sustainability. We wanted to do something in the long term, and we knew that in the least developed countries, our business, through the commercial investments that we had, were growing. So a percentage approach allowed a growing actual number to be enjoyed as the businesses grew. And 20% is an amount that we felt was significant, but also sustainable. If we did 50% reinvestment, I think we'd run out of the ability to do that quite quickly. If it was 5%, it wouldn't be enough. So 20, although slightly arbitrary, is a significant enough amount that we could actually have some impact with. And just to give some examples, in Bangladesh, that started off 5 years ago at just under £1 million. I think it was 750,000, and now it's closer to £2 million. So as the business grows, the amount that goes in also grows. And that's being seen generally across the countries that we work in. So how do we go about doing these programs? Well, I think, again, one of the things that GSK had to think about was how do you deliver health worker training programs? What's the best means of doing that? Who do you need to engage? And what's the mechanics of how you make this happen? We had to think carefully about that because we wanted to make sure that we drove ownership in country. We didn't want it to be seen as a north-south driven program where GSK potentially were deciding where to do programs and which therapy areas to focus those on. So really, really important was to develop the ability to work with country ministries of health and develop long-term solutions. And we decided to do that by working through NGO partners rather than us going directly with ministries of health where there were risks potentially of conflicts of interest and the ability to know clearly what the needs were. And so we decided to deliver the programme through 3 regionally based NGO partners. We picked Save the Children to support us in our programmes in West and Central Africa, AMREF Health Africa to deliver our programmes in East and Southern Africa, and CARE International to support our programmes in Asia. And by working with 3 NGO partners, it allowed us to have a blend of different but similar approaches and the opportunity to learn something from one another in the way that they programmed. And they all had quite a strong presence in the regions in which they supported the programme. So we worked through NGO partners. And the way that programmes were developed were absolutely always to be in line with what Ministry of Health priorities were. So, for example, in the programme that CARE does in Bangladesh, they would engage with the Ministry of Health right at the beginning alongside GSK to try and overlay what the Ministry of Health priorities were, what CARE's view on the health priorities were, and what GSK's were. And in and around that, a programme would be developed which addressed those priorities. And it was really important that that engagement happened, and really important that GSK locally were involved. Again, we didn't want it to be something that was driven from London. It needs strong ownership. And I think 2 of the individuals that we have here today, so Rumana Ahmed from GSK Bangladesh, who's sitting with us here, who's here for a couple of weeks, and Dr. Jahangir have really demonstrated how that's worked for us. Very, very strong local ownership. And I think we sometimes forget which one's working for GSK and which one's working for CARE. So frequent are the interactions that they have with one another. And it's really enabled a very strong programme to have developed. So we have these 3 NGO partners which deliver the programmes for that reason, and it allows GSK to be involved, but really the recommendations to be driven by the Ministries of Health and those partners. So what do they look like? So we said that we focus the investment on training health workers, but the other thing I've been touching on a few times has been on sustainability. So we don't just want to build an army of health workers and just leave them there, hoping that they will engage with communities and last beyond our funding period. So also critical in the way that we deliver the programmes are 3 other components that we support through the funding. One of them is the way that we educate and engage with communities. So we really need to make sure that any programme that's delivered in a country by our partner, such as CARE, involves the community and has them own as well the interventions that are being offered and delivered through the health workers. And that's really important. I consider that the demand side of things. The health worker training is the supply, and we need to create and stimulate that demand. And CARE, I think, do a fantastic job of engaging, educating and supporting the communities in a way that's very relevant to the educational and the cultural context that's there, to really encourage them to draw on the health workers that are trained. So it's really important that that supply and demand are created together, and that the community are owning and driving the things that the health worker provides, and providing a continuous feedback loop. So the Ministry of Health in the capital city knows at a macro level what the needs are, and that's really important. But I think the communities will surface local issues and help us to make sure that the programmes are appropriately tailored given the different communities that exist. That's one other component. The second one is what we call building capacity, very popular term in development, but really important, I think, from a sustainability point of view, that the GSK funding in a particular programme is not meant to be there forever. We want to try and stimulate change. And for example, in Bangladesh, in the particular community that we are working, we will be involved in it. The intention of setting something up that self-sustains, and then our role is to try and transport that to other areas. We don't want to be another part of the public health system in the long term in that way. So building capacity can involve training local, supporting local training institutions. It can be developing local groups to own the healthcare and so on. So there's a building capacity bit. And then lastly, the fourth component of any programme is generating an evidence base to support advocacy. It's really important that we use the work that we do to encourage governments to increase their investment in their healthcare systems. So that's a very quick summary of the programme, those 4 components: training health workers, which is the supply, working with communities, which is the demand, and the sustainability piece, which is about building local capacity and our advocacy efforts. And those four have worked together to help us make the programme what it is today. So just very quickly, the size of our investment, I said it's a percentage investment. So back in 2010, you can see there that in 2009, when we first started, the sum of the 20% reinvestment fund was 2.3 million. And that's grown year on year, almost every year, as you can see there. And this year we've managed to work to a level of 6.5 million. So quite a significant rise. And we've just committed to another 5 years of the programme. So I'm fairly confident that by 2020, we'll be putting over £10 million in through this programme alone into the least developed countries. What's the impact been? Well, I think the true impact is felt in the individual stories of the communities, but these numbers help a little bit. We've trained over 40,000 health workers to date. We expect that to rise to over 50,000 by the end of this year. And those health workers are currently reaching over 11 million people with improved access to healthcare. And again, we expect that number to rise to something like 15 million by the end of this year. But I think the individual stories, which you might hear later on, add a little bit of nuance to that, but really strong reach, actually, of the programme to date. So we have the programme in 35 countries. So there are 50 least developed countries. We have a business that generates profit in 35 of those countries at the moment. To date, as per that chart we showed, we've invested £21 million. And in that, we've trained the 40,000 health workers and reached 11 million people. So I think really significant reach and breadth of the programme to date. And then just looking at CARE, one of the three partners that we work with. So as Laurie referred to earlier on, we have programmes in Afghanistan and Bangladesh, but we also have programmes with CARE in Nepal, Cambodia, Laos and Myanmar. And £10 million has been invested in Asia to date across those 6 countries. And the numbers again show that we've trained 20,000 health workers and reached nearly 4.5 million people with improved access to healthcare. And I've been fortunate enough to be to 4 of the 6 countries where we programme, and I'm hugely impressed at all of the visits that I've done at the individuals who have been touched by this programme. The numbers are great, but I'm always very moved and very motivated when you meet individuals, either community beneficiaries or the health workers themselves who have been empowered and are delivering excellent healthcare as a result of this programme. So just to finish off with a few pictures that I actually took on my iPhone of various projects that I've seen. So this was the first one that I saw 3 years ago. It was an old iPhone, so if it's blurry, it's because of that. But this was in the far west of Nepal, very remote region. And this is something that CARE, again, I think just do such a great job of. So working with women in the community to map out in a very user-friendly way, given the education and literacy levels that exist in these communities, to help them understand the layout of the community, the pregnant mothers, those that have got appointments coming up that they need to have with health facilities, those that have given birth, the vaccinations that need to happen. And this is a great tool that CARE have developed, which really works and is adjusted to meet the needs of the community and really empowers them to draw on the health system. This is, as I said earlier on, that demand side, which I think is also important. This is a visit we did this February or March to Laos, a very different programme. So this is working in an urban area where there are large numbers of migrants who come into Vientiane from Thailand and from rural parts of Laos to work in the ready-made garment industry. And in these factories, there were very low levels of access to health. And through CARE, we're running a programme to encourage the factories to strengthen the health facilities that they have there, to encourage the workers to go and have health checks and to use their being at work as a point of accessing the health system, and to try and build confidence in people in using the health system. And I think CARE have done a great job, again, in doing that there and really supporting very vulnerable populations in accessing health in a very different way to Nepal. And this is another photograph from Laos, again working. This is a community. This is a volunteer from the factory. So the lady with the blue t-shirt is somebody that works in the factory who's received some training to CARE. So she's known as a peer volunteer or a peer educator, talking to some of her to some of the co-workers in the factory, encouraging them to use the health facility that's available in the factory. Really important, again, in driving that demand. This is from a week ago in Bangladesh. I think it's great there that you've got men and women around the circle there doing something very similar to what I showed in Nepal, drawing, using the community to drive demand into the health system. And that sheet of paper there has got a diagnosis that they've done on what their health needs are. And they surface those with the community health workers and the midwives there to ensure that the services that are being provided are fit for purpose. I think I've got one or two more slides. This is a ceremony that we had. The most important person there is the one, I think, in the white and orange. That's one of the midwives that has been trained by the programme, and some of the community health workers are also very important. And somewhere at the back, I'm there with Laurie and Svetlana from last week, and that was a fantastic visit that we and Dr. Jahangir and Rimana from a week ago in Bangladesh. And this is my last one, I think. Just a quick slide there showing an equivalent meeting we did in Cambodia. Again, that community piece where these are people from the community surfacing their needs. And the point of these slides is really to show the consistency that we've got across the programme. We work with CARE because they have a similar approach, which is locally tailored to drive that demand into the health system. And I think that's been hugely encouraging to see. So I think I'm out of time. So happy to take questions at the end, and thank you very much.
Thank you, Darryl. Yeah, we'll take some questions at the end. That was great. Lovely combination of statistics and photos of real people. So fantastic. Thank you. You talked a lot at the end there about that kind of community approach which CARE takes in a lot of these programs, and I suspect we'll hear a bit more about that from Dr. Jahangir as well. You also talked a lot about that importance to GSK of investing in the shortage of health workers. Building capacity, I think, is also a very unpopular phrase in the development industry as well as a popular one, because we all want to be so much more specific, and I think this is very specific that, you know, talking about training community health workers and midwives, etc., and that's great. One of the interesting things that we saw in Bangladesh, of course, is that the skilled birth attendants were being paid by the community who use their services rather than the public sector or the project. And again, that's something maybe we'll hear a bit more about from Dr. Jahangir, but I think might be something that people are interested in asking questions about later. So thanks very much. I will just check if anyone had any more clarification questions, but I think that Darryl was very clear personally, but if anyone has any clarification questions, we'll just make sure that you've understood what you've heard, and then we'll get more into the debate later. Okay, you all agree with me. That was a very clear presentation. Thank you. So we'll move on to Fiona in one moment, just to continue welcoming the people who are following us online, including from the WHO regional office in the Pacific in Manila. So fantastic. We're really getting into Asia with this story about Asia, which is excellent. And if you are talking about us online, then remember the hashtag is MNCHAsia. And if you want to talk about what Darryl's been saying, you might want to add the GSK handle at GSK. And if you want to talk about what Fiona's about to tell us about, her handle is ODI Dev. So now we will move on to our second speaker, Fiona Samuels from ODI, who, as I mentioned earlier, has been the co-author with CARE of these pieces of research on the project in Asia. So I hope you've all picked these up. Oh, sorry. So Fiona's a research fellow in the Social Development Programme here at ODI, a social anthropologist with over 15 years of experience across in the fields of social development and public health. Themes of particular interest to her and expertise include maternal and child health, gender-based violence, the role of gender and social norms in shaping adolescent girls' lives, mental health, psychosocial support services in post-conflict settings, HIV vulnerabilities and coping, social protection strategies, and many more. So Fiona's going to tell us a little bit about the research that she's done on these programs, capturing some of the main approaches and lessons that she's seen from our work across Asia. So over to you, Fiona. Thanks very much.
Thanks very much, Laurie. I didn't have the privilege of going there, but I feel going to visit the project sites, but I feel I sort of know them quite well now through reading the various project documents and speaking to the people and working very closely with Svetlana, who is my co-author on this and who manages the 6 projects for CARE in Asia. This is not my photo, but it's a picture of the private community skilled-based birth attendants, which you'll be hearing more about. I apologize in advance, there's lots of acronyms in this presentation, but hopefully we'll manage to get through this. Okay, just a little quick overview of the CARE-GSK partnership. You've heard quite a lot about it just now, but essentially it focuses on improving maternal and neonatal child health by increasing the quantity and quality of community health workers. As we see, it works in 6 countries: Afghanistan, Bangladesh, Cambodia, Laos, Myanmar, and Nepal. It is a 2-phase project. The final phase is just ending now, and it's about to start again from now until 2020. And one of the key focus of this approach and project is the issue of partnerships. And these have been taking place at all sorts of different levels and across different sectors, and have been involving the community, government, private sector, as well as the international community. Just to highlight some achievements from the phase 1 of the project, as we can see, over 16,000 community health workers were trained, and also over 4 million people were reached. Direct beneficiaries, i.e. those who are actually receiving the services provided by the project, and then the indirect ones, who are those members of the community who may have taken part in awareness-raising programs and these types of activities. In terms of the country context, this is very brief. As said, you'll see more details of these country contexts in the 4 documents, one of which is an overview, and 3 are country case studies from Afghanistan, Bangladesh, and Nepal. But as you probably realize, that they're very different countries and have very different progress in key health indicators. For instance, the maternal mortality ratio ranges from 327 in Afghanistan to 270 in Cambodia and Bangladesh. However, despite these very different contexts and progress in terms of health indicators, they all somehow face a set of similar barriers to improving maternal and child health care. And as we've heard, we've thought about them in terms of supply side and demand side barriers. So on the supply side, barriers include service provision in remote areas is patchy and often of poor quality. Many of the providers have limited capacity, and also there are limited incentive structures to actually encourage providers to go to some of these remote areas. In some countries, we also found that the providers were male, which, given the sort of social cultural setting of these communities and societies, makes women reluctant to take up these services. On the demand side, and as no doubt you all are aware, that distances to health services, transport costs, lack of awareness of the existence of the services, as well as limited mobility and the relative disempowerment of women and girls in these contexts also prohibits them from accessing services. However, despite these very differing contexts and different national level priorities and different programming approaches by governments and NGOs, all the projects in the 6 countries developed actually similar approaches to dealing with these challenges and barriers. And we've sort of grouped them into sort of 3 broad areas of approach, which I will go through in a minute. Just to say, in terms of methodology, we essentially reviewed the project data from the 6 countries. So we didn't go out and collect fresh primary data for this piece of research. It was a secondary data review. And it was also, we also took advice and support from all the country offices, making sure we were getting the right picture, that we had the latest up-to-date information. So it was a combination of myself and Svetlana, but also the country offices supporting us in this processes. So the first broad approach that we noted, and as we've also heard from Daryl, which was key to all the projects, was community involvement and mobilisation. As we've also heard, this is working on the demand side, and especially developing partnerships with the community through different approaches and processes. As a result of this sort of community involvement and mobilisation, not only are projects more based on local priorities and needs, but it also creates ownership, it is more sustainable, and it also develops empowerment among different groups. A key means of sort of developing and this process of community involvement was a training and capacity building of existing community health groups. And I think this existing is actually quite important. So CARE and partners didn't build structures alongside, but actually identified those that were existing and built their capacities. So in Nepal, I'm sure many of you have heard, the female community health volunteers are a critical cadre of health service provider in rural, remote areas. They're often the first port of call for women. And their capacity was built, and they worked with mothers groups. Also in Nepal, they had this cadre of peer educators who were trained, and they were both men and women, and they in turn would spread awareness amongst their peers in the communities. In Afghanistan, they have the family health action groups and the male shura committees, and I've put this sort of quote in red what these male shura committees are, because I found them very, very exciting, because they're essentially male members of the community who are opinion leaders and religious readers, and they meet on a regular basis. And they through the community-based educators in Afghanistan, their awareness around mental health was increased, and therefore they became sort of key champions of maternal health in their communities. And they in turn have distributed messages to over 200 male community members during events such as gatherings in mosques and other traditional events. I think we all know that involving men and boys in issues around maternal and child health is critical. And I think this is a real interesting way that has been done in Afghanistan to reach this group of key actors. The other form the other process of involving community members was through community surveillance systems and processes. And these are essentially systems where the members of the community monitor and track and collect data on other members of the community in terms of maternal health. So in Afghanistan, they developed the community-based surveillance system. In Bangladesh, they had community support system. And as we've heard, in Nepal, there was a set of participatory tools which were developed and used by members of the community to sort of track and monitor maternal health in their community. And this quote from this nurse in Kailali is very telling. The community health scoreboard is like a mirror where we can see our progress in a tangible way. This is a process whereby users of the services and providers of the services come together and basically discuss the challenges and barriers to service uptake and jointly develop a solution to this. And as we saw a similar photo that Daryl showed, this is actually the self-applied technique for quality health that they use in Nepal, where essentially women's groups or mothers' groups, again facilitated by the female community health volunteers, they get a blank chart and they map their community, and on the community they map the different stages of pregnancy of a woman, whether she's attended an antenatal care visits, the number of visits, etc. And this is a way of monitoring women, but also sort of identifying where there may be gaps and where they need to be filled in and how they can be filled in. Okay, so I talked about community mobilisation and involvement. This is now the other broad area where all the projects we're working on, and this was on focusing on the more formal side and working on health systems strengthening, and so also working on the supply side. And partnership here was essentially with government, as we've also heard. So there was a range of training of different levels of health work, including members of the community, and here you'll see lots of acronyms. But so you have community health workers in Nepal, the auxiliary nurse midwives, you have the community-based educators and community midwives in Afghanistan, etc., etc. And I think, from what the people who were trained said, this training was vital for them. It really empowered them with skills and knowledge, not just around maternal health, but also to influence people, to start people thinking about how they could change their norms and behaviours and underlying norms, which often affect health-seeking behaviours. This is a healthcare worker in Nepal. The other aspect of strengthening health systems was the development of infrastructure and distribution of supplies. So in a number of countries, infrastructure was built, upgraded and renovated. Also, there was a range of training supplies distributed, and also drugs and other vitamins and other family planning kits were distributed in these other countries. The The final area is partnerships and advocacy. Partnerships and advocacy are critical for scale-up and for longer-term impact and sustainability. In terms of partnerships, these have been with a whole range of different types of stakeholders, as I also mentioned earlier, including the private sector, government, NGOs, international community, as well as beneficiaries. So when looking across the 6 project, we found that partnerships took place both at project design level and also in project implementation level. So at project design level, partnerships with government consisting of ensuring that the projects were aligned with national level priorities. And also it was ensured that the government was involved in terms of coordination. For instance, in Afghanistan, the project focused on District 1 in Kabul, and this was identified as a priority area by the government as lacking in health services to cover the urban population. Another area which I'm sure you'll probably hear about later on is the government and other stakeholders were very closely involved in the design and development of the private community skilled birth attendant model in Bangladesh, and I think that was critical to ensure uptake and sustainability of that model. In terms of this sort of the involvement in project design is critical in terms of generating accountability, in terms of building capacity, again, of government and other stakeholders, but also creating ownership at that sort of government level and also beyond. Partnerships in terms of project implementation, so members of the health system, the formal health system, were often trained to ensure that they understood what was happening in terms of the community-based models, so that they could actually take on board people who had been trained through the CARE project once a project had left. And I think this was already happening in Afghanistan. The community-based educators and the community midwives were being sort of incorporated, absorbed into the formal health system. Obviously, another area of partnerships is in the form of technical input, which has been critical in all countries for supporting existing progresses. Members of the project teams have been involved in technical groups and task force meetings at various levels, at national, provincial, and lower levels. And these experts have been providing expertise and also developing these models for possible replication. Advocacy, again, this has been critical in all projects to share lessons learned, to ensure that processes are understood, that ownership is obtained, that they are scaled up. So these have involved advocacy at national and international level. The projects have developed different kinds of documentation. There have been newsletters produced. There have been promotional brochures. At international level, the project teams have disseminated their findings at different regional international fora and conferences. And as a result of this advocacy, it's actually led governments in some of these countries to start adopting the tools and approaches and increasing health resources, and approaches including increasing health resources. For instance, the Ministry of Public Health in Afghan adopted this babies tool, which is essentially a tool developed by CDC and CARE for tracking pregnancy, postpartum, birth weight, and age at death of women. It's a complicated acronym. It doesn't seem to quite match, but anyway, that's what it does. Just to move on to some quick conclusions and recommendations, and again, you'll see more of this in our documents. So obviously, continued commitment and buy-in of government and other stakeholders is critical. And I should say that actually, although there are country-specific recommendation and conclusions, what we're highlighting here are some ones which actually are relevant for all countries. And this buy-in from government and stakeholders should be also at quite relatively high levels. So, it's critical for that. And obviously, ongoing advocacy, learning and sharing of project lessons is critical, and also thinking through innovative ways of sharing this information through social media, through peer-to-peer exchanges, these types of approaches, through mobile phones. Strong, effective, sustainable and accountable community health systems are only achievable with the involvement of different levels of the health system. Again, just to stress again, these partnerships across different levels of the health system, both vertical and horizontal, are critical, and crossing both formal and informal, crossing both public and private, and also working across different sectors. Partnerships between the government and communities is critical. And I think the one thing that we found in all countries that continued investment in community health workers is very necessary in order to continue building their capacity, not just around health, but also broader issues. Also, we need to think about issues of incentives, attrition, and financial sustainability going forward in some of these contexts. And finally, a sort of broader issue, and something which we at ODI we've been working on a lot, is to think through the issues of social norms and discriminatory practices, which continue to affect the lives of many women and girls in these contexts. And I think we need sort of broader ways of dealing with this, sort of community-based approaches and dialogues, again, also involving men and boys in this, since this is so critical to any successful process. And I'll stop there. Thank you.
Thanks very much, Fiona. That was very helpful indeed, and I hope a great teaser for people to read the documents in more detail. And I think very interesting. I think you particularly added, I think, that role of government and how important that's been in several of the programs and at various levels. So, as I've also seen, everything from the kind of National Minister of Health that we met in Bangladesh last week, and as you say, to the male Shuras in Kabul that I met a few months ago. And CARE certainly does, in general, make a real effort to engage men and boys as well as women and girls in the work that we do around women's empowerment and gender equality, and the women that we work with encourage us to do that because they know how important that is. And I must say that the male Shura members I met in Kabul were just as passionate about improving the health of the women in their community as any female health worker that I've met as well. So it was great. So thank you for that. We're going to move on now to a bit more of a focused case study of Bangladesh with Dr. Jahangir from CARE in Bangladesh. If you want to carry on tweeting, remember it's #MNCHAsia. If you want to comment perhaps on some of the stuff that Fiona's saying, maybe add the handle ODIDev. Or if, as you're hearing from Dr. Jahangir, if you want to add the handle CARE-INT-UK, that would be great. So over to you, Dr. Jahangir, and thank you for making the trip all the way to London.
Okay, thank you, Laurie. Good morning, and thanks, everybody. I am going to share experience from Bangladesh, which is an innovative public-private partnership to address human resource for health issue in more underserved and remote areas in Bangladesh. So I will, the way just, it's like my presentation, though just I allocated 15 minutes, I will try to finish, but let's see just how we can do. And I had some, my presentation overview is the background and context, as because if you just give the whole context, I need to, and then project design, and then intervention description that I try to do very quickly, more results, achievements, and challenge and lesson learned. So that's kind of overview. I understand that you know that Bangladesh in Asia, and like 3 parts surrounded by India and Myanmar on the east. And if you see in Bangladesh, like there are 7 kind of division, and this Sylhet division is one of the low performing division. If you see some health status like this, the indicator maternal mortality ratio, and which is almost in Sylhet division is more than double the maternal mortality ratio. Like if you see the access to skilled birth attendance, that's also low to the national if you compare, even new natal mortality rate and total fertility rate. So it's give you some idea like what is the difference in Sylhet division to the other. And if we go to the like what are the reason for this kind of event? In Bangladesh we are on track on many Millennium Development goal, but in some area like Sylhet, we are lagging behind. And most important is non-availability of the skill service provider and inadequate functioning of this kind of health system in the in remote and geographically challenged areas like Sylhet division. and therefore there are lack of supervision monitoring, which goes to the governance issue, lack of accountability, as because there are less support. If you see the shortage of human resource for health in Bangladesh, just as per WHO standard, 2.3 skilled health worker should be per 1,000 population. If we see the scenario in Bangladesh, it's 0.6 per 1,000. And then, as because that's a supply and demand, like who covered this? Like these quack, drug sellers, and TBA, as because people need some kind of services. So they are occupying and they are kind of providing these services. And even the poor people, they are paying out of pocket expenditure in Bangladesh, which is 64%. And that actually just guided us to look at what we can do. Even if you see the Sylhet division, Sunamganj is further worse, like in terms of its health indicator and poor performing. Sylhet, Sunamganj is one of the districts. And you see that with 2.5 million population, and government is committed to address this issue, like, and government doesn't know how to do it. And just we are lucky in, like, we designed this project with the support from GSK with their 20% reinvestment initiative that you heard, and that helped us to design this project. I am just going through like how we designed. So like during the design process, we know there is issue, low performing, and all the BDS's data is showing low. Then government wanted to find some kind of solution, and then we just, along with GSK and other stakeholders, and we talked with Ministry of Health and WHO and other UN and civil society organization, and just discuss what to do, like what should we do differently, which is more sustainable and impactful. And then just a role of Ministry of Health, of Gynecological Society, local government identified, as because we should not train community health worker and come and it will not sustain. So there is a kind of discussion and understanding so that everyone kind of participate in the design process, and they recognize this as a public-private partnership to address community level human resource for health issues. So I am just, and there is a memorandum of understanding between CARE and Ministry of Health on this project. And the proposed solution is kind of, we just developed private community-based skill birth attendant. And actually, and there are some, for each of the skill birth attendant, there are 12 community health worker and supported by one community support group and supported by also local government. And we just, it's known as a kind of public-private partnership, as because everybody has some kind of contribution to implement. And like it's the purpose is kind of consistent access, quality services, and we covered 10 sub-districts out of 11 and 50 in one, which is the lowest administrative unit. And we trained more than 2,000 community health workers, 3,000 volunteers, and even local government is 700, and number of this public, also like other NGO providers. And we developed 168 community-based private skilled provider in Sunamganj districts. And on an average, they are covering 7,500 population. And the selection was kind of, they are married and using some criteria that is being used by government and Ministry of Health and WHO. And government and community were involved in the selection process, and they received the skill training, which is 6 months followed by 9 months on-the-job training at the field level, and they received some other training on primary health care, including family planning and community IMCI and like just health MIS. And quality assurance, just we are managing the quality assurance with government like this. We provided training to the government supervisor, and they are kind of using some different checklists. So they are visiting, and so that how they are kind of like using the algorithm and different step of the service they are providing. And refresher training arranged at the sub-district level, establishing some skill lab. And there is a kind of monthly joint coordination meeting between health, government, health provider and this private provider together so that they can share their kind of performance and how many women they registered at pregnancy, and they report, and this report is going to the government MIS system. And one of the uniqueness of this project, extensive commodity mobilization. We use commodity support system, which is tested model in Bangladesh, and government is replicating throughout the country. And we use that model, and each of the commodity support group, they identify, they track each of the pregnancy using the community map, and like you see, and they promote the birth preparedness, and they refer to this private provider as well as the government provider. They mobilize some local fund for emergency transportation. Also, they monitor the quality of service and uptake of service, especially see the equity issues, whether all the poor are being kind of served by this private provider as well. So they have some kind of role to make them accountable. And also the important part is the local government engagement, as because local government engage, and usually the local government, they don't have any kind of role on health usually. And then we advocate, develop their capacity, what they can do, and they have particular three roles that we find, like they negotiate and determine the service price of this private cadre, and which is very, and including community and the private provider, so that it is very transparent how much they will charge to whom, and poor and the well up, and allocate some fund so that the poor can reimburse, facilitate linkage with the kind of this referral facilities, and make them accountable, as because and this local government member, they share the community feedback to the government referral facilities. And another important part is the promote social entrepreneurship. These private provider are trained on just so that they know how to do their market analysis, what is their market size, develop individual business plan, and how to promote their kind of services, so that as a private provider and monitor it. And we are collaborating, our Jita is one of our social entrepreneur in CARE, and also like link them with the drug seller and commodity suppliers, so that they can get some supply and they can sell it out. And also like facilitate collaboration with the traditional birth attendant, village doctor, who are kind of like to minimize the unhealthy competition. And so that this TBA, they usually work as a kind of co-facilitator often with this new private provider. And there is at the national level technical advisory committee, which is being participated by Ministry of Health, chaired by Joint Secretary of Ministry of Health, WHO, UNICEF, UNFPA, and other NGO like Save the Children and some donor, GSK CARE, so that we regularly share the progress and challenges, and also lesson learned. And also we are being challenged, like so that how we can do differently, and whether it is aligned with the national Ministry of Health overall plan. And also these people, they act as a kind of advocate. And kind of like if we see the results, and which is like if we see that these numbers, and 68% of the service recipient by this private provider is poor or ultra poor. And you see the number of pregnant women and the children, they receive services. So, and if we see that the performance of individual private providers, and like service contact per month on an average is 100, which includes like 105 delivery and 40 ANC and postnatal care and child health care. And their earning, you see, that's also increasing in trend, which is 30, on an average 35 pound, like, and their 40 pound is their kind of benchmark for sustainability for that community. So it's like, and then if we see like so far it's like less than two years implementation time. In the baseline it was 12%, and as for the monitoring data, and it's very robust monitoring, it's 50% skilled birth attendant, and which is the MDG goal for Bangladesh. Millennium in Sylhet, the Sunamganj district, we achieved the Millennium Development Target, and of them 51% contributed by this new private provider. And accordingly, if you can see this, which is for ANC, is from 43% to 90%, and 47% is increased, and 54% contributed by this cadre. Accordingly, the PNC, which is from 8 to 50%, and also 64% contributed by this cadre. And the referral also, like it's as because you see the 12% of women attended at the delivery are referred, as because you know the 15% of delivery supposed to develop some kind of complication, and so that they are not holding them up, they are referring. And some key challenges is selection of appropriate this private skill birth attendant, as because 2.3% women only just they completed secondary level, and that's one of the challenges we need to find just to get the appropriate candidate. And inadequate functioning of the referral facilities, especially emergency obstetric care referral, that we just were collaborating with UNICEF and other agencies to strengthen that facility. Competition with the local traditional healers, and ensure social accountability of PCSBA. We don't make them there become another kind of more commercially oriented kind of private provider, so that how to balance the social and the commercial commitment. And geographical hardship. And the key lesson learned that we have, like private skill, these MNCAs, the maternal and child health provider, successfully replacing the unskilled and traditional provider in this kind of remote and unserved area. And availability of consistent and affordable, accessible skill service provider, and potentially sustainable alternative service delivery options for the people, as because before they have only government which is not functioning, and they have only the COAC and other kinds of traditional. So now they have some skill provider, and it is possible to exploit community and local government commitment to address financial, social, and governance barrier in accessing health services, so that local government, they are allocating fund and they are kind of providing all this kind of social service. And we find it's very innovative public-private partnership model proving to be, as because we need to do some more robust evaluation, effective to address both geographical and wealth inequity in accessing health services. And last week, like Laurie and Doril was there, and Health Secretary he was kind of making comment, okay, just we have enough information, just we need to see more kind of parallel funding to go to the other unserved district. We cannot wait. So then that's his kind of comment and the commitment. Thank you all.
Thank you, Jahangir, and perfect timing as well. Jahangir showed one photo there quickly to show to try and show the remoteness of Sunamganj, where the project's working. But I have to tell you, it was really remarkable to see that last week. So we flew to the Sylhet region, which Dr. Jahangir mentioned, and then we got in cars and we drove non-stop for 3 hours on what seemed to be literally the only road. There were no forks in the road. And on either side of the road, as far as you could see, were flooded fields. And it truly is a very, very remote part of Bangladesh. I forgot actually to ask if anybody had any clarification questions for Fiona, and if people also have any clarification questions for Jahangir, let us know now. Otherwise, we can move on to our last presentation, then we'll open it up for more discussion. Okay, great. Well, thank you to all of the panelists so far for such clear presentations. So we will now move on to our last speaker, Cara Hansen from the London School of Hygiene and Tropical Medicine. Thank you for coming. As I mentioned, Cara is the Professor of Health System Economics at the London School. Her research is focused on the economics of health system financing and organisation in low and middle income countries, and has included work on health financing arrangements, the role of the private sector in health systems, and the economics of delivering particularly malaria interventions. She's a co-research director of RESIST, which is the Resilient and Responsive Health Systems Consortium. She has a doctorate from the Harvard School of Public Health and joined the London School in 1997. So we're looking forward to hearing a bit from Cara about what you might draw out from what you've heard and read from today's panel in terms of broader lessons that there may be in terms of the role of the private sector in strengthening health systems and health financing, and as well about different models of private and public partnerships that we have. So thank you very much.
Thanks, Laurie. So it's such a pleasure to be here, really for two reasons. One is to be able to link with alumni from the London School. So Dr. Hunger and I have discovered that we both joined the London School at the same time. So I don't think I taught him, but I was there at the same time. But also I started my career as an ODI fellow. So I sort of feel like I've come around circle today because I haven't had the opportunity to be here before. So what I'd like to do is just step back a bit and think about where this particular model of a public-private partnership fits into the broader landscape of public-private partnerships, and particularly how we can think about these sorts of interventions and programs as contributing to a health systems approach to addressing and dealing and working with the private sector. And it reflects thinking that's developed over a large number of years and conversations that I've had with Barbara McPake from the Nossel Institute. So we talked today about this one particular, a variety of forms of public-private partnerships, and I think the private community health workers in Bangladesh give a particular focus for what I'm going to talk about now. But this is part of a hugely varied set of relationships with a really heterogeneous set of actors. And so this, that doesn't come out all that well. This slide here is a way that I've used for years and years to begin to unpack the diversity of public-private mixes that we see in health systems around the world. And what I think is really useful is to distinguish between provision, which I've got going across the top axis, and financing down the vertical axis. And you can imagine these four sort of boxes of different types of public-private arrangements. So in the public-public corner, we've got our classical tax-funded public health system, but we can also have public monies going to private providers. If you think about things like the RSBY scheme in India that uses a private insurance agency to channel public funding to a mix of public or private hospitals that are providing services to below poverty line families. You can have private financing going into public provision through user fees or informal charges, or a variety of models of private money going into private provision. And I think things like the investment from GSK into the development of this private cadre of community health workers is an example of this. But even these boundaries are fuzzy, that they don't describe the full complexities of these relationships. So we've got public sector doctors who also work in the private sector. We've got hospitals that are notionally fully publicly owned in China, but run in a very marketized and entrepreneurial system and respond to market incentives. We have pay beds in public hospitals and charity beds in private hospitals. And these, even our community health workers that we've heard about this morning, are actually receiving funds from a variety of different sources. They get some government funding to serve particular communities. They also receive out-of-pocket, they receive payments from community members, and then their training and the other sort of infrastructure of the project is provided through some of the funding from GSK. So it's a very much more complicated set of relationships than you'd imagine from my first diagram of these. Oh, I think I might have sent the wrong version of my presentation. I think that's probably why it's not So that's my fault, not yours. So what I wanted to say here was that because of these fuzzy boundaries, it's really difficult to find a single indicator of how important private provision is, because we know for sure that private spending, that we have quite good data on, doesn't actually tell us about how much of provision is in the private sector. And so the figure that's supposed to be here describes the private share of total health expenditure, and it ranges from about sort of 5 or 6% through to 80 or 90% in countries, but that itself doesn't tell us how much private provision there is. So those data are useful, but they're not that helpful because they can't really distinguish for us where private payments are being used for public services. But that data does tell us that those data on private expenditure do tell us some very important things about progress towards universal health coverage. And so this is a scatter plot here that relates the share of spending that's out of pocket on the horizontal axis to the share of households that incur catastrophic expenditures on the vertical axis. So we know that those private payments that households are making can sometimes lead to to financial catastrophe for households. And that's really what progress towards UHC is partly getting at. It's really trying to protect households against these large, unexpected and unplanned for out-of-pocket payments for health. So as we've seen, the private sector is diverse. So this is the sort of what you might think of as the high-tech, sophisticated, high-quality end of the private sector. These are some sort of middle-range things. The bottom is a franchised public clinic in Kenya and a private pharmacy at the top. But we've also got this kind of private sector, very much more informal, taking place in rural communities with poorly trained providers, perhaps with commodities that haven't been kept safely. I appreciated Dr. Jahangir's comment about quacks, because this is the sort of area where you might see some quack doctors as well. Also, a new actor in this whole field is private training institutions. We see a real development and expansion of private medical schools and nursing schools and dental schools. I wish I had a picture of a private community health worker. I'm going to ask some of you for your photographs afterwards to add to my selection here. And this is another way of depicting that heterogeneity, that we've got different forms of ownership, we've got corporate hospitals, we've got individual owners, we've got different profit orientations, nonprofits and NGOs and for-profits, and we've got different levels of care running through from the community and primary care levels right through to tertiary hospitals. Now, what we've seen, if we look for some of the patterns that develop across countries in public-private mixes, is that the private sector thrives in the gaps that are left. And so when the public sector or its NGO partners are failing to provide affordable quality services, we see quacks. That's there is demand for services that is not being met, and so the private sector will respond. Similarly, we see the tertiary hospital sector emerging, where the public sector isn't providing hospitals that are acceptable to those who are well off. The story's still there, it just doesn't look so good. And some of the challenges, I think, particularly with those of us who are concerned about community access to care, is really for that low-quality, informal end of the spectrum. If well-off people are spending large amounts out of pocket in tertiary hospitals, I'm not so worried about that, but I really am worried about people spending a lot of money on very low-quality care. And so there have been lots and lots and lots of programs and interventions to address this. There are training programs and social franchising programs and social marketing programs. But to be fair, these sets of activities are very largely externally supported, therefore do have some sustainability challenges, and it's very rare to see them replicated and sustained at scale. So I want to just turn briefly to the Sustainable Development Goals, and what do they make us? How should we think about the private sector in the context of the Sustainable Development Goals that are due to be adopted in the next few days at the UN General Assembly? So there's a whole bunch of health targets, but there's also this other target for universal health coverage. And what do we mean by universal health coverage? It's protecting households from out-of-pocket expenditure and ensuring that they have access to the services they need at good quality. And so the targets that have been developed around monitoring progress towards UHC are around protecting households from out-of-pocket expenditure and ensuring at least 80% coverage of essential health services. And there's a whole monitoring infrastructure that's being developed around tracking progress towards UHC. So we kind of know where we want to get, but how do we get there? So a number of different types of analysis point us to the critical role of public pooled funds for universal health care. So there's some evidence that's been put together by Peter Smith and colleagues showing that where health expenditure is predominantly pooled and public, and by public I mean both tax-funded and social health insurance, that health improvements arise from that. It's really important to have public pooled expenditure. But it's also really important to have public expenditure to drive access as well. So these scatter plots are looking at the relationship between government health expenditure as a share of GDP, so you can think of that as government's commitment to health, and the share of treatment that takes place with unqualified providers. And you can see the patterns aren't very clear, but governments that are not spending at least 4% of their GDP on health are really not able to protect people from using unqualified and potentially unsafe providers. So we can see that government expenditure is important both for both elements of UHC, for financial protection and for ensuring access to high quality services. I'm right at my last slide. So we know where we want to get. We know that it's really important to have public commitments in terms of funding, and we know something about the role of the private sector and some of the sort of small-scale approaches that have been taken to addressing some of the quality problems that we can find in the private sector. But how, at a system level, can we ensure that the poor have access to good quality, affordable services that can effectively compete with and crowd out that low-quality private sector? So I was very excited to see the results of the Bangladesh study here as pointing to one model that can create some effective competition for that really low-quality private sector. More generally, there is a need to make sure that effective and affordable services are available. And there's lots of different ways to do that. You can do that by providing an effective public health service. Or governments can do that by engaging with the private sector through contracting or through these community-based arrangements. I would say in terms of how do we get there to universal health coverage, what it's also going to require substantial increases not only in government funding, but also in government's capacity to manage pluralistic health systems. Because in the end, public funding nor public provision are going to meet all the healthcare needs of populations and the demands of populations. So there are going to be important spaces for private provision, but government really needs to be in a position to manage that and to secure health for all. And as well as those purchasing arrangements, they're going to have to be able to strengthen regulation, because that regulation is what is going to be able to ensure that both at the very low quality end, that those private providers are not responsible for services, but also at the high quality end, that households are also protected from very high out-of-pocket payments, and also that the services they're providing are effective and safe. So I wanted to close with just a couple of questions that we might reflect on in our discussion about what is the broader role of the private sector as we advance towards this new SDG of universal health coverage. What can the range of stakeholders that we've heard about here contribute to ensure access to affordable and quality essential services? And also in the medium to long term, how can we make sure that these efforts are integrated into health systems, that we end up with is a health system that serves the needs of everyone? Thanks.
Thank you very much, Cara. So we're going to move very shortly into questions from all of you. Really looking forward to hearing those and the panel's response to them. Just first, as with others, if there's any clarification questions for Cara's presentation, let me know. I'm sure, by the way, we can probably share the presentations that people gave or wanted to give and online along with the documents afterwards, so people can see some of the graphs that they didn't get to see of yours, Cara, which would be great. But I think you described that curve very effectively. My suggestion for the Q&A is group a few questions so that they can kind of bounce off each other a bit more, and we can turn it into a bit more of a conversation as opposed to very kind of scattered different questions at different times. So I'm going to start by suggesting, are there any questions about broadly this program with GSK and CARE in Asia, maybe particularly what Daryl and Fiona were talking about? Then I'll take any questions which are a bit more specifically, that if people want to hear more of the details from Bangladesh, from Dr. Jahangir. And then if people want to ask any questions that kind of like draw out the bigger lessons for public-private partnerships in health particularly drawing on Carl's presentation. And then if there are any that don't fit into any of those buckets, or maybe if they're detailed questions on some of the other countries, we'll do that. And I think we've got time for those 4 groups, so hopefully that'll work. We will see if we get any questions in online, and I'll throw those into the mix if we do. So if you are watching online, please do send us your questions. And so in a minute, I'm going to ask people if they have any questions for that first bucket. So be thinking about that. Just while you think about it for 1 second, I realised that I didn't actually do my proper introduction for Dr. Jahangir. No, so I will, because it'll give people a minute just to think about their questions. It's always a good excuse. So I did mention that Dr. Jahangir is in charge of all of CARE's health work in Bangladesh. So that covers community health, but also HIV and nutrition programs in Bangladesh. That means he's working with government, NGOs, alliances, UN organisations, etc. And I was particularly interested to hear about the technical advisory group, actually, which I hadn't picked up on last week in Bangladesh. That sounded great. He's got special interest in community health systems, as you could hear there, but also health governance and sustainable solutions for addressing health inequity for the poor and vulnerable. And I know he was a big champion for us picking one of the poorest places we could find in Bangladesh for this programme. He's a registered physician. He has a Bachelor of Medicine and a Bachelor of Surgery from the Dhaka University in Bangladesh, as well as an MSc in Public Health in Developing Countries from the London School, as Cara mentioned, which is what made me realise I hadn't said that. So thank you for doing that. Okay, so now let's go to some questions. So first of all, any broad questions about this community health programme in Asia that we're doing with GSK and the research that Fiona had done. So I can see a couple of hands already there. Are we doing mics?